Welcome to this OCISS webinar on abstracting prostate cases using the WebPlus online portal as part of cancer reporting to the state of Ohio. In this webinar, we will go over the abstracting guide for prostate cancer. We will review some general abstracting tips, but please make sure that you have already reviewed the WebPlus overview webinar before watching this one. That webinar explains functionalities of the WebPlus system that will not be covered here. This webinar will focus on abstracting tips that are specific for prostate cancer. Most of the content of this webinar is material that is available in the downloadable Prostate Cancer Abstracting Guide on the OCISS website. The abstracting guide is divided into 3 sections. The first page has some general notes and tips. The second section is the bulk of the guide, which takes you through the entire WebPlus reporting form and how to abstract prostate cancer cases. The remainder of the guide is made up of a 1-page quick reference for some of the data fields, along with detailed information on the summary stage data field that is frequently used in national statistics and by researchers in their analyses. These references are referred to throughout the abstracting tips in the second section. We will start with some highlights from the first page of the abstracting guide. First, even though the information on data fields like those related to patient demographics is applicable across all types of cancers, the guide is developed specifically for prostate cancer. If you have questions about an unusual cancer case or another type of reportable cancer seen at your facility, please contact OCISS. Before you start a new abstract on a patient's cancer, please first check that your facility has not already reported it. There is a Find Open Abstract function in WebPlus that was covered by the WebPlus Overview webinar. This is especially important if multiple staff does the reporting at your facility, or if you are a new staff taking over the reporting. We do not want you to unnecessarily duplicate work. The Find Open Abstract function is also useful to find any unfinished abstract that you have started and saved but not yet finished. About 95% of prostate cancer are adenocarcinomas that originate from the glandular tissue of the prostate. These are also referred to as acinine adenocarcinomas. The histology code is 8140. Per national guidelines, this type of prostate cancer is only reported once in a patient's lifetime. Your facility may be following a patient with early-stage prostate cancer over several years, and the patient may have multiple positive biopsies in that time, but only the initial diagnosis and first course of treatment needs to be reported. If your facility is involved in the treatment of the patient's cancer and you are expecting to receive information regarding the first course of treatment, please wait to finish and release the case to the state. An exception would be if waiting will severely delay your timely reporting of the cancer within 6 months of your facility's diagnosis and/or treatment of the cancer. Please save and save often when you are in WebPlus. Any unsaved work is lost when WebPlus times out. Every time as you save, when you're completing the form, you will notice edit errors on the right-hand side. You can disregard these until you have finished the abstract because most of them, if not all of them, will disappear as the form is completed. These are highlights of some of the general notes and tips. Please read the abstracting guide and review the overview webinar for other notes about using WebPlus. We will now go through the WebPlus reporting form. The screenshots in this webinar are based on the physician reporting form as of fall of 2018. There will be some changes to the form in late 2018 to early 2019, and the anticipated changes will be pointed out during this webinar. Each abstract that is sent in on a patient's cancer summarizes information on a patient and a specific cancer of theirs, which includes information on the cancer, how it was diagnosed, and how it was treated. Please note that only the first course of treatment is reported. So let's get started. The first section is on patient information. Most of this section is self-explanatory. A helpful tip to remember for this section is to use 5 leading ones when you only have the last 4 digits of a patient's social security number. Enter a string of 9 nines when you do not have social security information. The primary payer is the insurance information. There are lots of choices here when you use the drop-down menu, but please note there are several not otherwise specified, or NOS, options if you're not sure about the more specific codes. And then as a reminder, the address section is for the patient's place of residence when they were diagnosed with the cancer. As mentioned in the overview webinar, information on apartments, units, suites goes in the supplemental line. Some general tips in this section applies to the entire form. For example, all date fields are in the year, month, day format, and date flags are paired when you see them together on the form. Never will both a date and its corresponding flag be filled in at the same time. This is because the flag is only used to explain why there is not a date in the date field. So when there is a date, the corresponding flag will have to be blank and vice versa. If you need a refresher on this section of the form and the different icons and the menus, please review the Web Plus Overview webinar. Next section of the form deals with the diagnosis of the cancer being reported. A key part of the abstract is the diagnosis date, so this is required, with the corresponding diagnosis date flag being blank if you see it on the form. A patient diagnosed in late 2017 somewhere else may be at your facility for treatment in 2018, but that doesn't change the fact the patient was diagnosed with the cancer in 2017. So the case is still considered a 27 diagnosis year case. Please note that if the patient was not diagnosed at your facility and you don't have an exact date, incomplete dates such as May 2017 without an exact day can be entered as just 201705. The calculator button will automatically calculate the patient's age based on the date of birth and date of diagnosis that you entered. If you see that the calculated age is very different than the age of the patient as you see in their medical chart, please double check that you have entered the date of birth and date of diagnosis correctly. The primary site code for prostate is C619, and even though there are different lobes of the prostate, for cancer registry purposes, it is not considered a pair site. So laterality is 0 for prostate cancer. Histology is almost always 8140, as mentioned previously, because 95% of prostate cancer is acinar or just plain adenocarcinoma. Use the magnifying glass if you are reporting on a rarer type of prostate cancer. Reportable prostate cancer is invasive cancer, so behavior code will always be 3. For grade, we're going to reference the quick reference guide. This is a screenshot of the grade section of the quick reference. It gives a simple table to convert the highest Gleason score from the cancer, whether it be from the biopsy or surgery if that was done, based on the diagnosis year. So for example, a highest Gleason score of 7 is grade 2 for diagnosis year 2016. Grade is a data field that will be changing for cancers diagnosed in 2018 and later. For prostate cancer, there will be a more distribution among Gleason scores 7 through 10. And we already show that in the table. As you see, Gleason score of 7 could be a grade group 2 or 3 depending on the patterns that make up the score. And Gleason 8, as you see in 2018 and later, will be split out from a score of a Gleason 9 and 10, whereas in previous years, 2014 through 2017, Gleason's 8, 9, 10 will all group together as grade 3. So use this table when you need to code grade, depending on your diagnosis year. A note about the text fields in this section. These are very important and serve not only to provide information not otherwise coded in the rest of the abstract, but also to support and validate the codes entered. For prostate cancer, the primary site and laterality text is simple. It's just prostate. Note the difference between the histology and pathology texts. The histology is just a description on the type of prostate cancer along with the highest Gleason score. The text documentation of the Gleason score helps confirm the grade that is coded. The Gleason patterns that make up the Gleason score is also documented because they are an important prognostic indicator, as we saw in the last slide, and is important for determining grade group for diagnosis year 2018 and later. Pathology text is where summary from the path report is documented. Depending on the path lab, the report may list every single core from a prostate biopsy or just give you a summary. You do not need to list every single detail from the path report, just the summary. We have included an example text here for guidance. Please feel free to use abbreviations such as some of the ones shown here. There are 4 other fields in the diagnostic section. Diagnostic confirmation. Most common is 1, when cancer was diagnosed or confirmed by some kind of tissue specimen. Date of first contact is the date when your facility first had contact with the patient for this particular cancer that is reported. If your facility diagnosed the cancer, this is usually the same as the date of diagnosis. If your facility is only participating in some of the first course of treatment, it will be the date the patient started those treatments at your facility. Sequence number. You can leave the default 00 for sequence number unless you know of other cancers the patient had in his lifetime. Class of case can be a confusing data field, and there are lots of choices when you click on a drop-down menu. So we ask that you refer to the quick reference. The data field describes your facility's relationship with the diagnosis and treatment of this particular cancer. For example, if the cancer was only diagnosed at your facility, but all treatment was referred elsewhere, the class of case would be 00. For prostate cancer, please note that active surveillance, also referred to as watchful waiting, is considered a first course of treatment option. So if your facility diagnosed the cancer and the first course of treatment is active surveillance, and the patient is being monitored and followed at your facility for that, the class of case would be 10. Next section of the form is on diagnostic procedures. The 2 most common diagnostic procedure codes are 02, when biopsy is done on a prostate to diagnose or confirm cancer, and 01, when a diagnosis is done from sampling a metastatic site, such as a lymph node. As mentioned before, date is in year, month, day, and corresponding flag is blank when you have a date. Physical exam is a text field where you will document the workup on the patient. We gave some examples here as a guide. The brief description of the patient, such as 65-year-old white male, is very useful to validate the demographic information, such as the patient's gender, that was entered up in the demographics section. You will enter information for x-rays and other imaging if that was done. And then a note about the laboratory tests. A patient may have multiple PSA values over the years. What gets documented here is the highest PSA value before anything was done to the prostate, because procedures such as biopsies can elevate the PSA value artificially. A change for diagnosis year 2018 and later that is pertinent to prostate cancer is a new data field specifically for collecting PSA lab value. It records the last pre-diagnosis PSA lab value before biopsy and treatment. This field will allow you to record the actual measurement in the nearest tenth of a nanogram per milliliter, and the format of the field will actually include a decimal. When you have an uncertain value, such as less than 5.0 nanograms per mil, code the closest value to that, which would be 4.9 in this example. There's also a special format for this data field when PSA lab value is greater than 1,000 nanogram per milliliter. Next section of the form is on first course of treatment, starting with surgery. Common treatment status codes for prostate cancer, especially when the disease is localized, is 2, which is active surveillance or watchful waiting, and 1, which is treatment given, whether it be surgery or radiation or another type of treatment modality. Date of first course of treatment is the date of the first treatment modality, no matter what it is, whether it be surgery, radiation, or something else. If the treatment is active surveillance, the day that the decision was made goes in this data field. Reminder that flag is blank when you have a date, but if you don't have a date, for example, because surgery wasn't done as first course, then you will select an appropriate date flag. For example, flag code is 11 when there is no date for surgery because it wasn't part of the first course of treatment. A useful clarification between surgery and date most definitive surgery is that it allows you to document more than one surgery if that was done, with the more extensive surgery date in the most definitive date of surgery field. But if only one surgery was done, for example, prostatectomy, then surgery and most definitive surgery date would be the same. We will now refer to the quick reference for the surgery code. This is a screenshot of the surgery code section of the quick reference. For example, a patient had transurethral resection done for benign prostatic hyperplasia, and prostate cancer was found incidentally when a specimen was examined by pathology. If the patient did not have any other surgery done as first course of treatment, surgery code would be 22. Another example, patient with a rising PSA and normal DRE has biopsies that showed prostate cancer, then the patient goes on to have only radiation as first course of treatment. In that case, surgery code would be 00. Back to the form, surgery text is where the surgical procedure information is documented, and we have also provided some example text as a guidance. Surgical margin choices are given in the drop-down menu. 9 if it's unknown, 8 if no surgery was done, etc. The scope of regional lymph node surgery describes how extensive the lymph node surgery was, and you can use the drop-down menu again to select the appropriate choice. Something that's been confusing for reporters in the past is the regional nodes positive and regional nodes examined. This refers to the pathologic examination of lymph nodes by a pathologist, and 98 is the code if no nodes were examined in the regional nodes positive field. 00 in the regional nodes positive field would mean that lymph nodes were pathologically examined, but none of them were positive for cancer. Please use the drop-down menus for non-primary site surgery and reason no surgery. A helpful thing to keep in mind is that an abstract tells a single story about the patient's cancer, so fields that relate to each other should be consistent. For example, you have a patient who had radiation and no surgery as first course of treatment. As such, treatment status will still be 1 because treatment was given, it just wasn't surgery. And you will code the date the radiation started as of date of first course of treatment. There will be no flag, date of surgery will be blank, flag will be 11 not performed. Surgery code will be 00 because there was no surgery, and you can document that in the text. Margins will be 8 because there was no primary site surgery, there was no lymph nodes removed, there were no lymph nodes examined, so regional nodes positive is 98 and examined is 00, etc. And finally, you will have a start date for the radiation because that was the first course of treatment. The rest of the first course of treatment is on other treatment modalities. These include radiation and systemic treatments such as chemo, hormone, and biological response modifiers, sometimes known as immunotherapy. We listed some of the common types of radiation for prostate cancer here in the guide. Something that might be confusing is the radiation surgery sequence and the systemic surgery sequence. If either radiation or surgery was not done, sequence is 0. There is nothing to sequence if one of them wasn't done. Only when both are done as part of first course of treatment would there be a sequence. For example, radiation was done after surgery. The logic is the same for systemic surgery sequence. The guide also includes tips if you have a case where the patient had active surveillance as treatment. And all these treatment modalities would therefore be not done, with blank dates and 0 for the surgery, radiation, and systemic surgery sequence. The end of the first course of treatment section lets you document any unusual experimental treatments that doesn't fit under surgery, radiation, or systemic treatments in the other fields. Something that is specific to prostate cancer is oropectomy, removal of one or both testicles, is a type of endocrine treatment, so it is actually coded here in the transplant treatment code and not in the surgery section. There is also a reminder about this in the quick reference in the surgery code section. Last section of the form that documents information on the cancer is the cancer staging. Summary stage is a basic way of categorizing how far a cancer has spread from its point of origin. The drop-down menu for this is very brief, but the data is very important, so we have included the full description for prostate cancer in the appendix. For diagnosis year 2018 and later, there is a new but very similar data field called Summary Stage 2018, and we have included full details for that in Appendix B. If you have cancer stage information in the medical record, please document that in the staging text. Something has to be in this text box, otherwise you will get an edit error. So even if you have no information at all on stage, at least put unknown or no information instead of leaving it blank. For tumor size summary, you can use 999, which is unknown, or document the greatest diameter of the cancer in millimeters. If you are a physician's office using the physician reporting form, this should already be populated with 999 for you. Site-specific factors are part of a data collection system called Collaborative Stage. These fields should already be populated with default values if you have clicked on the magnifying glass for the regional nodes positive examined up in the treatment information section. If they are blank, click on the first magnifying glass in this section to populate them. For prostate cancer, 3 of these site-specific factors has to be filled in. They are all 3-digit fields. The first one is site-specific factor 1, which records the highest pre-biopsy PSA value to the nearest 10th digit. This is a commonly miscoded field, so we have included some examples here. And you should have also documented the PSA in the laboratory text box up above, so it will help us to verify that this field is coded correctly. The second is the site-specific factor 8, which is the highest Gleason score from the needle core biopsy or from TURP. Last of the 3 is site-specific factor 10, which is the highest Gleason score from the prostatectomy. So if the patient did not have prostatectomy, the code is 998, which is prostatectomy wasn't done. Please do not code Gleason score from other procedures in this field. For diagnosis year 2018 and later, all of these site-specific factor fields will be left blank, or you may not even see them on the form. You will have reported PSA in its own field, which we covered several slides back. And please continue to document Gleason score in the histology and the pathology text boxes. Here is a quick screenshot of the first page of Appendix A, which is Summary Stage 2000. Summary Stage 2018, which you will find in Appendix B, is used for diagnosis year 2018 and later, and is very, very similar to this, except it has additional helpful notes and clarifications added. AJCC TNM staging is a cancer staging system developed by the American Joint Committee on Cancer. If you do have AJCC staging information, you can enter it, and we highly recommend that you use the magnifying glass lookup because the form only allows the fields in very specific formats. As non-hospital facilities, however, you can leave the section blank, and the defaults as you see on the screen, you can leave them as it is. Either way, please document in the staging text box any staging information you have in the medical record, whether it be AJCC or another type of staging system. The 2 data fields for CS tumor size and CS extension is only on the other reporting form, and it only needs to be completed if you have a case that is diagnosed before 2016. For all reporting forms, if you see the override CS20, please make sure that that is blanked out for cases diagnosed in 2016 and later. For diagnosis year 2018 and later, all of the AJCC and CS staging data fields will be left blank. The data fields you see with a gray background, such as CS version input current and original, these are defaulted and unchangeable, so you don't need to worry about them. We are now at the last section of the form. The managing physician data field is the physician's Ohio license number. Please use the magnifying glass to look up the doctor by name. If you do not find your doctor listed, or if his or her information needs to be corrected, please contact OCISS. Until OCISS adds the physician to the lookup choices, you can use 8 zeros to indicate the patient and the physician is not listed. The NPI or National Provider Identifier for the physician can be filled in if you have that information, but the field may be left blank. Date of last contact is the latest date where there was contact with the patient, whether at your facility or where the patient might have been referred to for treatment. Important thing to note is that this date should be the same or later than any other date reported on the form. Otherwise, you will get an error. Common reporting source type and case finding source have been listed here as shown in the abstracting guide. Your facility, OCISS ID, and your initials will automatically populate in the reporting field and the abstracted by field. And lastly, in general, leave the site type and override age site morphology fields blank. These are only used for very, very unusual cancer cases. An exception you might see with prostate cancer is if you have a man younger than 40 being diagnosed with prostate cancer, in which case you will get an edit error for that, and you may need to set the age site morphology override. As we went through this form, you may have wondered why certain data fields are there if they are not always relevant for prostate cancer cases. Please keep in mind that the same reporting form is used by different facilities who see a variety of different cancers. Here is a summary of the anticipated changes for diagnosis year 2018 and later for prostate cancer. First, there will be a new grade data field that will continue to be based on Gleason score, but it gives a greater distinction among Gleason scores 7 through 10. There will be a new data field dedicated just to collecting pre-diagnosis PSA lab value, and it will include a decimal in the field. Summary stage 2018 is very similar to SEER summary stage 2000, but with helpful clarifications added. These were the learning objectives for this webinar that we have completed. Thank you for reporting cancer cases diagnosed and or treated at your facility and for watching this webinar. Feel free to re-watch or review portions of this webinar as needed, and please refer to the downloadable abstracting guide from the OCISS website. Here's the contact information for OCISS. Feel free to contact us if you have any questions, concerns, or comments. Thank you for contributing to the completeness, quality, and usefulness of cancer data in Ohio as we work together to reduce the cancer burden in Ohio and improve cancer patients' lives. Have a great day.